Adolescents, by way of Pittsburgh. Let's give it up for Kate Harrigan.
What a fabulous introduction. Very fitting for the last seminar of this semester. I'm really happy to be talking today about a project I've been working on for the past couple of semesters. It's about the cost effectiveness of web-based depression programs for adolescents. Please pause. There we go. All right. So I worked with a whole bunch of people on this project, and I wanted to give some acknowledgments before I started. Shirley is a pharmacy student in her 4th year that's been working on this project with me throughout. Dan Touchette is our lovely advisor. And also we had some folks from the PATH research group, Dr. Van Voorhees and Monica, and then the whole research group who was also there have been instrumental in our project. Thanks for coming today. So here's an outline for my talk. First, I'll be talking about some background information about depression and about web-based interventions. Then I'll be talking about my objective. We'll have a lengthier discussion regarding methods. Then we'll go into results, discussion, conclusions, and a Q&A. But also, I'm saving the Q&A for the end, but if you have questions in the middle, feel free to interrupt and ask. So before I get started, I do want to note that I'll be referring to both depressive symptoms, major depressive disorder, and depressive episodes all as depression throughout the presentation. So I'll kind of be flowing back and forth between those terms. And I did this because of the way some of the trials we used for our model included patients and what their inclusion criteria was. So if you hear me flowing back and forth, that's what I mean. So I'm sure everyone's aware that depression is a really common health problem in the U.S. and in the world, both in adults and adolescents. So the estimated one-year prevalence is about 4 to 5% for those in mid to late adolescence. And that prevalence has been increasing over the past 10 plus years, in particular among those ages 12 to 25, and that's the population that we looked at in our project. So also not surprisingly, depression is expensive. It leads to higher annual healthcare expenditure compared to those without depression. One paper found that the annual outpatient expenditure for those with depression was about $5,000, and about half that for those without depression. So here's some data from the NIH showing the past year prevalence of major depressive episodes among U.S. adolescents, and this is from 2016. So the first bar shows the overall prevalence, which is about 12.8%. Next, it breaks it down by sex. So as you can see, females have a higher prevalence than males. The next section breaks it down by age, and you can see that the prevalence increases as people go through adolescence, and it peaks around age 16. And finally, it's broken down by race in the last set of columns. So of those adolescents who had a major depressive episode in 2016, about 70% of them were considered to have severe impairment. Furthermore, if you look at the pie chart on the right, those that did have that major depressive episode, 60% of them received no treatment at all, which is a problem, as many of you can imagine. So, again, like I showed before in a couple slides ago, that prevalence of depression increases by age. It's known that prevalence of depression is fairly low in children. It kind of rises dramatically as people go through their teenage years. So there's been lots of papers out there discussing why this might be. And so I've listed some possible factors for this on the slide, and I'll go through them. So one is genetics. It's commonly known that genetics play a role in developing certain health conditions later in life. Also, I know I remember, I don't know if you all remember, in your teenage years, there's some increased parental conflict. So it seems like there's a little more conflict in the home, and that can be stressful for adolescents. Also, traumatic events goes kind of hand in hand with some of that parental conflict, as well as other things that can happen into the teenage years. especially with social media these days and being in high school, it can be traumatic. Also, as you know, going through puberty, there's a lot of hormones, and that can kind of change the brain chemistry, causing you to be potentially at risk for developing depression or depressive symptoms. A couple of slides ago, I showed that females have a higher prevalence of depression than males. One paper stated that females reported increasing stress levels more so than males. So that's maybe one of many reasons why females have a higher prevalence of depression than males. Ineffective coping skills is another one, as well as self-consciousness. I was self-conscious in high school and middle school. I'm sure everyone went through the awkward phase. But again, that plays into some of these reasons and all these factors together that can cause an increasing prevalence of depression. Some of these factors can not only cause depression, but can be a consequence of depression. So things like poor peer relationships. It's hard to say if that is caused by some of these factors or some of these problems, or if that's a result of being depressed. So it kind of creates a cyclical situation. So I wanted to find or present and talk about a conceptual framework that kind of pulls together all these factors that I just talked about, and will also relate that to where certain treatments work for combating or decreasing depressive symptoms. So on the left, I have stress and vulnerability, and there's a couple constructs that make up this section. One is chronic or acute burdens, which are things like life events, and that could be that increasing parental conflict or other traumatic events that happen through someone's life. There's also the biological environment, and that's genes. The psychosocial environment would be things like demographics or different interpersonal situations. So all those factors kind of interplay with your risk of developing depression. Underneath the depression section, there's a couple of constructs that make that up. One is physiological factors, and this could be things like the hormones or the imbalances in neurotransmitters that happen. And a lot of medications, SSRIs and some other medications for depression work in that space. And then there's psychobehavioral factors, and this is like coping skills. And that can have a big influence on if someone's developing depression and how severe it is. Finally, all these things affect someone's health outcomes. So if someone has depression, of course they are going to have worse health outcomes in the long run, especially if they've had it for a long period of time. It can definitely affect things in morbidity and mortality. So since our project was evaluating web-based interventions, I wanted to talk about why they're appealing, is there any evidence behind them working, and what a typical web-based program is, because they're not overly common. So it's been shown that over 90% of adolescents use the internet daily. This can make these programs appealing because people are already using the internet. Additionally, it allows for anonymous participation. A lot of adolescents and adults in general are afraid of being stigmatized, and that could be a reason why people aren't seeking treatment. So this could be a potential answer to some of those fears. Also, like I mentioned, high accessibility. The internet is very accessible for most people. Many web-based depression interventions have shown a decrease in both depression and anxiety symptoms, so we know that many of them do work in decreasing symptoms. So a typical web-based program, typically there's modules or lessons that participants will take. I wrote some common themes for these modules on the slide. There are many, but here are some common ones that I've seen in many of the different interventions that I've looked at. So it looks at things like confidence and self-esteem, problem solving, goal setting, and challenging negative thoughts. Some interventions also have online chats, games, or homework assigned in between modules, and they can be provided by a number of different professionals, such as a healthcare professional, a social worker, a school counselor, or a teacher. So I just wanted to point out before we move on that a lot of these internet programs are working in the psychobehavioral factor arena. It's kind of targeting coping skills. We can't change someone's genetics or a lot of other factors going on in their life, so a lot of these programs target coping skills, which is the area in the box highlighted. So there are no head-to-head trials of these web-based interventions, and doing that may not be feasible. There are also no cost analyses of these programs. So I'm hoping that this analysis would be able to inform coverage decisions for payers. We know that web-based programs typically are not covered. There's been an increase lately in talking about telehealth, but it hasn't progressed to the point where a lot of these web-based interventions would be covered by a payer. So before I move on, I want to go into my objectives. In our project, we looked at different web-based interventions, and these are models that we ran. When we ran the models, each intervention was run separately against its comparator from the clinical trial. So it's almost like we had 5 different models that we were running. So we didn't run each one against the intervention specifically. It was the intervention against its comparator from the clinical trial. So the population would be adolescents with varying depression severity, and that varies by study because all the programs enrolled slightly different populations. The web-based depression programs also vary by study, and I'll be doing a review of those next. Additionally, the comparators, as you can imagine, were all different. Our outcome was the programmatic cost necessary to meet a threshold of cost effectiveness. So essentially what we were trying to do is determine at what cost would we be able to deliver these interventions to meet some threshold to be able to consider them cost effective. We were kind of working our models backward in a sense, and I'll explain that more when we get into the results. The time horizon varied by study, but it ranged between 3 and 12 months. Again, we're trying to inform payer decisions and coverage decisions, so we used a payer perspective for this project. And then we had 2 different thresholds. We had a threshold of 100,000 per quality gained, and also a threshold of 0 per quality gained. I know typically we're taught, at least in a lot of classes, or we see commonly that the thresholds are 50,000 per quality gained, 100,000 per quality gained, or 150,000 per quality gained. It's not as typical, I think, to look at a threshold of $0 per quality gained. So I'll explain that more when we get to the results and we have some numbers to look at.
What does it mean, 0 per quality gained?
It's essentially a break-even cost analysis, but yeah, so I'll explain that when we look at numbers, but yes. So a literature review was conducted to identify web-based depression programs, and we selected 5 programs to include in the model. Again, each intervention was evaluated separately against its comparator from the trial, as I mentioned before. So on the right, I have a table of the different programs that we included. The first one was the Competent Adulthood Transition with Cognitive, Behavioral, Humanistic, and Interpersonal Training. The next one was the Depression Alcohol Project. GRASP was Grasping the Opportunity. MYM was Master Your Mood. And then SFBT was Solution Focused Brief Therapy. I'll be referring to these as the abbreviations for the rest of the presentation. So since we had so many different programs, I wanted to give an overview of not only the study length, but what the intervention group received and what the comparator was for each of the trials. So for Catch It, the study length was 1 year. The intervention group received the Catch It Internet program, which consists of 14 online modules. Some of the topics were strengthening behaviors, thoughts, and interpersonal relations. The intervention group also received motivational interviews from the PCP, which occurred at baseline and follow-up, and phone motivational interviews a few times throughout the study period. The comparator also received the Catch It Internet program, but instead of motivational interviewing, they received brief advice only from the PCP. The next study was DEAL, and that was a 6-month study length. The intervention group received the DEAL Internet program, which again were online modules. Topics were things like psychoeducation, assessment and goal setting, behavioral activation and change, mood monitoring, and coping with tough situations. So again, a lot of these are working in the coping skills space. These individuals also had homework assigned after each module. The comparator, they also received an online module program, an internet program, but they had fewer modules, and also the topics were a bit more broad. They were things like environmental health, physical and mental activity, nutrition, and relationships, and they also did not have any homework assigned. So here are the last 3 studies. GRASP was 8 months long. The intervention group received the internet program and phone counseling. The internet program had online modules, and it had built-in questionnaires and exercises as people completed the modules. An example of the topics for these modules was identifying and tackling depression. And again, like I mentioned, they had telephone counseling available to them. The comparator did not have any depression-related services. They had access to an anti-smoking website only. The next program was MYM. It was a study length of 3 months. This one had chat group sessions surrounding various topics like your mood, tracing negative thoughts, and challenging negative thoughts, and they had home exercises assigned. The comparator was actually a wait-listed control where the participants in the comparator group were invited to enter the intervention after 3 months. And finally, SFBT was 4.5 months long. Again, it was online chats, and it was more individualized sessions focused on goal setting. And again, similar to MYM, the comparator was a usual care wait-listed control group where they entered the intervention after 4.5 months. So as I mentioned previously, all the studies enrolled slightly different populations. So I have all the programs, the percent that were female, the mean age, and then the depression measure used for the clinical trial, and this was the measure that we used in our study as well. So all of the programs had more females than males, which probably isn't surprising. MYM had the program with the most females. The mean age also varied by study. The youngest overall was GRASP, and the oldest was DEAL. Ketchit and DEAL used the PHQ, which is the Patient Health Questionnaire, to measure depression, and the other studies used the CESD, which is the Center for Epidemiologic Studies Depression Scale, to measure depression.
Okay.
Yes.
A couple of them use some old folks. So do you adjust for adolescents if the need is over 21 or not?
Yes, but the range did fall below. So yeah, but I agree. It's kind of like adolescents and young adults. But yes. So I wanted to show some graphs talking about the intervention efficacy in the clinical trials. So on the right, I have the scoring that we used to put people into our model. These studies use the PHQ. Traditionally, the PHQ not only has a mild depression score category, it also has moderate depression. We combine those into mild depression. And also, traditionally, the PHQ scores moderately severe and severe, which we combined into severe. And we did this in order to be able to fit our model structure and to be able to find the utilities and values we would need. So the solid lines on the graph are the intervention group, and the dotted lines are the comparator, or the control group. So you can see from the graph that DEAL enrolled a more severely depressed population compared to Ketchit, as the average baseline PHQ score was higher. However, both programs, the intervention and the control, decreased the PHQ score over time, but to varying degrees. So I have a similar graph for the studies that use the CESD score. Again, we had to alter the typical CESD scoring categories based on our model. SFBT is the blue, and they enrolled probably the most severe population by CESD score, and then MYM, and then GRASP. The interesting thing about GRASP is that the intervention group, which is the solid purple line, didn't really seem to get better over time, but the control group did appear to get worse as their score increased from baseline to the end of the intervention. So we developed a semi-Markov model to simulate the effects of various web-based intervention programs on depression severity outcomes in adolescents. Again, what we were trying to do is use the models to determine the cost of each program required to meet some threshold of cost effectiveness. Typically when you do cost effectiveness, you have all the costs, like you would have the drug cost. and you plug all that into your model and you're calculating an ICER, we didn't have the cost of the program, so we were working backwards to see what cost it would need to be in order to meet a threshold of cost effectiveness. So effectiveness was measured in terms of qualities gained from moving from a state of severe depression to a state of lesser severe or no depression. Our cycle length was 1 month. We used half cycle correction, which is typical of Markov models. We did not discount because none of the study lengths were over 12 months. And then all costs were inflated to $2017 using the Personal Consumption Expenditures Healthcare Index. And our model was created and analyzed in Triage Pro. So here is our model structure. Patients could either start the model in a state of no depression, mild depression, or severe depression. Death was our absorbing state, so once patients cycled into death, they couldn't leave. For the other states, every month, since we had a 1 month cycle, patients had the chance of staying in that state or cycling to one of the other states. We also had a couple of transition states, and these were for severe depression only. So for patients who were in severe depression, not only did they have the chance of staying in severe depression or moving to mild depression, no depression, or death, they also had the chance of having suicidal ideation and a suicide attempt. After that, they would cycle back to one of the Markov states. So I wanted to give an overall idea of how the models flowed. Since we did have different interventions and the populations were different, I made these diagrams for each of the studies, again, just to give you an idea of how people were flowing through the model. So again, I have a figure here, and this is very similar to our Markov structure or our model structure that I showed you on the last slide. This one is specific to Catch It. The size of the arrows represents the volume of people moving from one state to the next. So if you remember from Catch It, it enrolled a slightly less severely depressed population. So a lot of the patients were starting in mild depression as opposed to starting in severe depression. That's why the arrow is very large from going from mild to no depression, because lots of people were moving to that state. The risk ratios are kind of a separate concept. The risk ratios tell us how the intervention versus the comparator moved people between these states. So if you look at the risk ratio for mild to none, it's approximately 1, and that means that the intervention was about as good as the comparator at moving people from a state of mild depression to a state of no depression. And again, for the Catch It trial in particular, the comparator group also received the internet program, so that might be why that risk ratio is 1. They both did a good job at moving people from mild to no depression. For severe to mild, it's a risk ratio of 1.25, and that means for anyone that did end up in the severe depression state, the intervention was slightly better than the control at moving people from severe to mild, and that's similar for severe to none. So I have these, again, for every program that we did. SFBT enrolled a more depressed population or a more severe population. So there were a lot more people starting in severe depression than maybe Catch It. So the arrows, again, represent the volume of people moving from state to state. So there were a lot more people starting in severe depression, so there were a lot more people flowing out of those states. And again, the risk ratios tell us how the intervention compared to the control at moving people from state to state. So for the severe to none risk ratio, that's a 4.7. That means that the intervention was much better at moving people from severe to none. Similar for moving people from mild to none, the intervention was much better than the control. And it was a bit better for moving people, the intervention was a bit better than the control at moving people from severe to mild, as you can see from the risk ratio of 1.28. MYM was very similar to SFBT. There were more people starting in severe depression than in mild, like Catch It. So again, you have a lot of people moving out of the severe state and into a state of lesser depression. And similar idea with these risk ratios. The intervention was much better than the control at moving people from severe to none. But it was about as good as the control at moving people from severe to mild. And I'll be talking later about how we calculated these risk ratios, so if you're curious, hang tight. So GRASP was a study where the intervention group didn't really get a lot better, but the controls seemed to get worse. So that's why there's a bigger arrow moving from mild depression to severe depression, because some people in that control group were clearly getting worse, and that's why the post-intervention score for the control group was higher. It increased. So again, same idea with the risk ratios. The intervention was better than the control at moving people from severe to none. It was similar at moving people from severe to mild, and it was a little better than the control at moving people from mild to none. And then DEAL was similar to MYM and SSBT. There were more people starting in the severe state and the mild state. And again, that's why those arrows are large. Similar with the risk ratios, the intervention was much better than the control at moving people from severe to none, and much better at moving people from mild to none, and similar at moving people from severe to mild. So we had to make some assumptions in our model. The first one is that being in the intervention group does not directly affect the probability of having a completed suicide attempt. So what this means is that we assume just because someone was in the intervention group, that doesn't mean that they would have chosen a less lethal method of suicide if they had a suicide attempt. Also, as I stated earlier, the risk of suicide and suicidal ideation was for those who are in a state of severe depression only. And we recognize this is an assumption, and just because someone's in a state has mild depression, that doesn't mean that they can't have a suicide attempt or suicidal ideation in real life. But it's an assumption we made for our model. Also, excess mortality is only due to suicide. So patients in any of the states had a risk of dying, but people in a severe state also had the additional mortality risk from suicide. Maximum of 1 episode of suicidal ideation per person per month, and similar, there's a maximum of 1 suicide attempt per person per month. Again, because our cycle lengths are 1 month. So when we were running our model, the first thing we had to figure out was what proportion of patients will be starting in each of our Markov states. So how many people are starting in a state of no depression versus mild versus severe. Unfortunately, the clinical trials only give the mean and standard deviation of the baseline depression score. So we need to figure out how do we determine the proportion of patients starting in each of those states. So we use bootstrapping. The overall goal of bootstrapping is to make probability statements about a population parameter. In our case, this was the baseline score. We were trying to determine the baseline scores. So we used repeated random sampling to obtain simulated patient-level results, and we did this by creating a sample from a distribution. Once we had our simulated sample, we were able to calculate the proportion of patients starting in each of the states. So I wanted to give you an example of how a simulated population would look for the baseline scores. So in order to bootstrap, you have to decide on a distribution that would best fit your data. We chose a gamma distribution. We were between changing or altering a beta distribution and a gamma distribution, and when we ran the models with both, the gamma seemed to fit the data a bit better, which is why we ended up using a gamma distribution. So on the graph on the right, I have our distribution of baseline scores for the GRASP study. So you can see this is a frequency graph. So the most common score, the most frequent score was 11, somewhere in between 11 and 15. So you can kind of see from this how we determine the proportion or how many patients were starting in no depression, mild depression, and severe depression by the brackets I put on the graph. The table on the left shows the parameters that we use for each of our studies in order to bootstrap the baseline distribution, and these were the means and standard deviations of the baseline scores in each of the studies. So we did a similar idea for determining intervention efficacy. We also bootstrapped risk ratios with a gamma distribution because that's what's recommended in order to determine someone's post score. So what we did is we divided the post score by the pre-score from the trial and calculated the variability around the risk ratio in order to bootstrap it. Once we had our bootstrap risk ratios, we were able to apply those to the baseline depression scores that we had bootstrapped previously. So an example would be if we had a simulated patient with a CESD score of 30 from the bootstrapping, and if their bootstrapped risk ratio was 0.5, we would multiply 30 times 0.5 to get 15. So that patient started the trial at a score of 30, and by the end they were at a 15. So that gave us our transition probabilities. We were able, if we did that for all of our simulations, we could determine what state they started in and what state they ended in. So what were the transition probabilities of moving from state to state? And again, we did this for all of our different interventions because they all had different efficacy. So here I have our cost inputs. Again, all of our costs were inflated to $2017. And again, all of our cost inputs were the same for each model. The things that differed between the 5 models were the baseline population and the intervention efficacy. All of these costs were the same for each of the models because we always needed the cost of mild depression, severe depression, suicidal ideation, and then the cost of the suicide attempts. So the one thing to note here is that it's very difficult to find the cost of suicidal ideation in the literature, so we had to use kind of a proxy. So we found the average cost of a hospitalization with a principal diagnosis of depression, and we used that for our proxy of the cost of suicidal ideation. And you'll notice that the cost for an incomplete suicide attempt is a lot more than the cost for a completed suicide attempt. Part of that is because these costs include hospitalization. So someone who has an incomplete suicide attempt very likely has a longer hospitalization stay than someone who has a completed suicide attempt. So the costs increase. So here I have our utilities and disutilities for no depression, mild depression, severe depression, suicidal ideation, and then a post-suicide attempt. Since we used monthly cycles, we inputted the monthly values into our model, but I put the yearly values for you here as well because they're a little bit easier to conceptualize. So again, many of our transition probabilities came from people moving from state to state, and those were bootstrapped. However, there were still a few left, one being mortality. We calculated that using data from the CDC vital statistics. Also, for those who were in the severe depression state, they had a chance of then moving to suicidal ideation or suicide attempt. So for those who were severely depressed, they had 5.4% of them would go on to have suicidal ideation. Of those who had suicidal ideation, 19% had an attempt, and of those who had an attempt, 27% completed. So here are our results. Again, how I generated these results was I plugged in different costs of the intervention in order to meet that 100,000 per quality threshold. So these are all monthly costs per person per month. So if we look at SFBT, basically what this means is their program could cost $458 per person per month in order to still meet that cost effectiveness threshold of 100,000 per quality. And the reason is because SFBT delivered more of an effect compared to its comparator, so it delivered more benefit compared to the comparator. So it could cost more and still meet that cost effectiveness threshold. The lower end was Tetchit, and again, they had more of an active comparator, so their intervention group didn't decrease the scores as much compared to the comparator because it was a fairly active group. So the cost per month is lower for them. It would have to cost less in order to meet that cost effectiveness threshold. So then we move on to the $0 per quality. Again, you can think of this as a break-even analysis. So this is essentially the cost of the program where the cost is offset by the savings of the program. So another way to think of this is if we can deliver any of these interventions for less than these amounts, then we'd be talking about cost savings. And that's pretty rare when we're doing cost effectiveness analysis. So we just talked about some of these programs that hopefully will be eventually covered by insurance in order to be more accessible and be delivered in a cost-effective way to be accessible for adolescents and young adults who are experiencing depression. Untreated depression, you can kind of think of it as a negative feedback loop. For a lot of people, small amounts of stress can stimulate building of new skills and resilience, and that's kind of like a positive feedback loop. If you get through one thing, you feel more confident to get through the next. It allows people to deal better with the next stressful event. However, depressive symptoms can cause a deterioration of that resilience and those skills, and that in itself is a negative reinforcing loop and negative feedback loop. The depressive symptoms can cause lower resilience, leading to an increased likelihood of a future depressive episode. So being able to deliver interventions that could make people less depressed, improve their depression scores, maybe we'd be able to stop some of these negative feedback loops from occurring, especially while people are young and in adolescence and young adulthood. So our model was from the payer perspective, so we didn't include any societal costs. So we likely actually underestimated the true benefit of a lot of these programs. Long-term societal costs are a lot different from a short-term insurer's perspective. So things like productivity loss, we didn't include in our model. One paper I found stated that productivity loss was the largest portion of the cost when they were calculating the overall cost of depression, and we didn't include a lot of that in our model. Also, many of these interventions can continue to provide benefits beyond the intervention length. So our model was run for the study length of the trial, so we captured all of the costs, but probably didn't capture all of the benefits. So again, coverage decisions for these programs may be informed by this study. It's likely that these programs could potentially be cost savings for plans. Again, the SFBT intervention, for example, the cost to meet $0 per quality, that break-even point was $86 per month. Maybe we'd be able to create a program where we could deliver that intervention for less than that and be cost saving. One study I found showed that it approximately costs payers $225 per month to treat individuals with medications, and a lot of our programs fall under that threshold. So the next steps will be to look at robustness of the results by running sensitivity analyses. We didn't have time to do that, but we'll be doing that next. And also potentially try to capture some of the long-term impacts of these programs. Again, we ran it for the study length, but it's possible that they continue to deliver benefit beyond the period of the study length. That's it. I'll take questions.